We will welcome everyone to our presentation from the Department of State Hospitals called Meeting the Needs of the Incompetent to Stand Trial. My name is Harold Turner. I'm the Executive Director of NAMI Urban Los Angeles and also serve on the Board of Directors for our state organization, NAMI California. Thank you for being here. Okay, so with that, I'm going to turn it over to Stephanie at this point.
Good morning, everyone. Just checking to make sure I'm off mute. Yep. All right. Well, good morning, everyone. I'm Stephanie Clendenin, Director for the California Department of State Hospitals, and it is an honor and a pleasure. I'm always very excited when I get the reach out from Jessica asking me to participate in NAMI's events, and it's really the opportunity to engage with individuals who unfortunately have had the opportunity to engage with our system, and it's always a unique opportunity for me to get some time to spend with you all to answer your questions and to talk with you about what's going on across our system. Today, I'm here to talk about individuals who are committed to the Department of State Hospitals as incompetent to stand trial. I'm really focused on individuals who are found incompetent to stand trial on felony charges and the efforts that are going on throughout the state around meeting the needs. Let me see. Having some technical moments here. There we go. So first of all, just a little bit about the department for those of you that may not have had an opportunity to engage with our system. We are the California Department of State Hospitals. We operate 5 state hospitals. They are located throughout the state. They're very large inpatient acute psychiatric hospitals, and we last year served a total of just under 10,000 patients throughout our system. Last year's number that we served is a little lower than what we normally see through our systems in a year, and a lot of that was due to the impacts of COVID-19 and the impacts that the pandemic had on our ability to safely admit and discharge patients in and out of our system. We also operate the conditional release program for individuals who are transitioning back to the community after a stay in the state hospitals. We partner with the county sheriffs to operate jail-based competency restoration programs. We have a tremendous partnership in LA County to operate community-based restoration programs and partner with many counties throughout the state to provide diversion programs for individuals found incompetent to stand trial. We serve a number of different types of individuals that are committed to the department. Today, we're going to be focusing on the incompetent to stand trial commitment type. But we are also serve individuals who are committed as not guilty by reason of insanity, offenders with a mental health disorder who come to us after their prison term has completed, individuals who also come to us after their prison term who have been found to be sexually violent predators. We serve individuals who are currently committed to the California Department of Corrections who need inpatient hospitalization. And then we also serve individuals who are civilly committed and need a state hospital and acute psychiatric level of care. So I want to take a historic look about across the utilization of state hospitals and really as it relates to individuals with serious mental illness and kind of the transition to the engagement in the criminal justice system and how that has kind of transpired over the course of history. And so we're going to take it back. We're going to take it way, way back to 1850. And when the state hospitals really started to be developed and implemented, we saw nationally, about under 2,500 patients committed to state hospitals. This grew over the course of just several decades to 150,000 patients in state hospitals. And then in 1923, there was a study done, and Penrose spoke about the balloon theory. And this was a study on the relationship of mental health hospital beds to crime and prison population. And he argued that by increasing the number of mental institution beds, society could reduce serious crimes and imprisonment rates. And from there, we saw the state hospital populations balloon. We saw by 1955, we had across the state hospitals across the nation, we had over 500,000 patients in our state hospitals. At that point, we started to see the deinstitutionalization of our state hospitals, but without ensuring that there was an adequate community network of services for individuals that were transitioning out of the state hospitals. So we started to see the state population drop, and in 1972, Dr. Mark Abramson, who was a jail psychologist, in his study reported that he was seeing a 100% increase in mental health arrests from 1968 to 1970, and really starting to see individuals with serious mental illness who were being criminalized. And then by 1978, we see a study by Dr. Sosowski, where in his study, he's seeing 301 former state hospital patients, individuals who were transitioned back out to the community with markedly higher incidence of arrest. And then in 1988, we see in a study by Dr. I'm not even trying to say the name, who reports that an examination of the nature and operation of an IST commitment reveals its potential to emerge as an alternative to civil hospitalization. And so this is where we start to see that an increased utilization of the IST commitment in order to begin to try to get individuals access to mental health care. And then by 2010, in a study by Tory, which is a survey of the states, more mentally ill persons are in jails and prisons than in hospitals at this point. And so this is really just a kind of primer to what we're going to talk about, which is this growth in the individuals, in the rate in which individuals are being found incompetent to stand trial and committed to the Department of State hospitals. And we've just seen a very substantial growth in this trend. So we actually in 2010 started to see an increase in the number of individuals that were being committed to the department as IST. And this is just looking back at the last 5 years, what has happened. And so from 2017 to 2021, we've seen a 29% increase in our referrals of felony IST commitments. And that's a growth of 305 individuals being committed to the department per month to 394 individuals per month. And we've seen a much greater increase in the number of individuals who are waiting for access to a treatment bed for restoration of competency services. And that's been a 173% increase. We have grown from 2017, a wait list of 528 to a wait list of 1,400. And it's even higher now today at over 1,600. And the very sharp increase is really tied to the pandemic. Prior to the pandemic, we were at around 800, and we've seen that wait list grow and double as a result of the impacts of the pandemic on our system. So where are the referrals increasing across California? This is showing, we're looking at the rates by county. And the rates by county, looking at the blue counties, those are counties where either we've seen no increase or even maybe a slight decrease to a very marginal increase in referrals. And then those that are in the light orange to dark orange reflect a moderate to substantial increase in referrals to the department. So just trying to touch a little bit on this commitment type for those of you that may not have experienced or are familiar with this commitment, but it is individuals can be found incompetent to stand trial on either, it's under Penal Code 1370, and they can be either found incompetent to stand trial on a misdemeanor charge or a felony charge. And this is when individuals are found incompetent to stand trial when they are unable to understand the nature of the charges against them, or really actively be able to participate in their defense as a result of the symptoms of their mental illness at the time. And ISTs that are, individuals found incompetent to stand trial with a felony charge are the responsibility of the state and are usually treated at the Department of State hospitals, although we have developed other programs so that they not everybody is treated in a state hospital any longer. IST treatment is typically very short term and focused on competency restoration. Under the law, it really is around stabilizing the mental health condition and teaching defendants about basic court procedures so they can go back to trial. So it is not designed to be long-term mental health treatment for individuals. Unfortunately, what we have seen is that it's become a pathway to getting some treatment, but it is not obviously the best pathway for individuals, and certainly isn't a pathway for individuals to receive community, long-term community treatment and supports. It is a national problem. It is not just a problem here in California. Our medical director here at the Department of State Hospitals tracks kind of the headlines on what's going across nationally. It keeps a repository of those, and these are the ones related to individuals found incompetent to stand trial and the growing rate of them nationally. And we see, Colorado, we see Dallas mentioned, Seattle, Wyoming, Delaware, Pennsylvania, Utah, New York. This is just, it's going on across the nation. A National Association of State Mental Health Program Directors forensic study, this was back in 2014, in the states that participated in the study, 75% reported the demand for forensic services has increased across their state hospitals, and 78% of the states responding reported that the increased demand for forensic services has required that they maintain waiting lists for admission, very similar to what we are experiencing here in California. They also, in the study, reported a 74% increase in the number of forensic patients in state hospitals from 1999 to 2014, and a 72% increase in the number of IST patients from 1999 to 2014. So very substantial increase nationally in the number of individuals found incompetent to stand trial. This is showing the change in population over time as we talk about kind of the deinstitutionalization and the change from civil commitments to forensic commitments. And you can see through our state hospital population here in California, what we're seeing in the gray line is the decline of the of individuals who are civilly committed in our system, and the reduced population as we moved individuals back into the community. And then we see a very sharp kind of and stable climb in our forensic population. So individuals that are being committed to us through the criminal justice system. And this is not just reflecting individuals who have been found incompetent to stand trial. This is all of our forensic commitments. So that would go back to the slide where we had all of the list of all of our commitments. This is reflecting all types of commitments to the state hospitals. For IST commitments, this is this slide is just showing the steady increase in the referrals. So this is for the number of referrals each year to the department. It's grown from 2,900 in 2014, and we saw it grow all the way up to 4,500 in 2019. And then we do see a drop in 2020, but that drop is unfortunately just a pandemic-related drop during the first months of the pandemic, which we saw courts shut down during the stay-in-place orders. As the nation shut down, we saw our court shut down too, and so we saw a drop in the referrals. Unfortunately, I think I would just note that what we're seeing now is that those referrals are now increasing again, and have reached higher than pre-pandemic levels. This is just showing the commitment the department has made, the state has made to increasing capacity to try to respond to the number of individuals that are being referred to the department as incompetent to stand trial. We have been year over year increasing capacity, and this is a cumulative year-to-year look. So from 2012 to 2021, we have increased by over 1,000 beds, and that has been both at the state hospital level, across our jail-based competency treatment programs, and in the community. And this is just reflecting the number of individuals that have been served each year as under this incompetent to stand trial commitment. And this, reflects that we've grown from 3,900 individuals in 2014 to 6,000 individuals in 2019 that have been admitted into our programs under this commitment type. So why is this happening? And that was, after a couple of years of the increase and seeing that it was continuing, and we were building capacity, and as fast as we could build it, more individuals were being committed to us from the courts. We had to stop and ask, why is this happening, and what more can be done, and what can we do to try to reverse this trend? And so we started to look to the data on the individuals that we were serving through our system. We have a great partnership with UC Davis Health, where we have researchers involved with our system. And Dr. Barbara McDermott there had been studying this population at the Department of State Hospitals hospital in Napa, and collected years of data that we took a look at to see what could the data tell us about the population that is being committed to us. And what we found is looking at this data from this one hospital in our system, and that the admissions from 2009 through 2014, so a 5-year look across to see if there was any change in the individuals we were serving or any themes through the data that we saw. And we saw no significant changes over time in diagnostic profile or demographics across the individuals being served. The primary diagnosis data here that we're showing, you'll see kind of this decline in the blue line and increase in the gray line. This really is not any change. There was actually a change here in between 2011-12 and 2012-13 that in the Diagnostic Statistical Manual, DSM-4 to DSM-5, and this was just a reflection of the change in categorization and how things are coded. But overall, no change in our in diagnosis or demographics of the population that we were serving. What we did find, though, in the data is that we saw a significant increase in the number of individuals and the percentage of the individuals who were committed as incompetent to stand trial, who had 15 or more prior arrests. So in 2009-10 fiscal year, we saw 18% of the individuals coming in with 15 or more prior arrests. And in 2014-15, that had increased to 45% of the individuals had 15 or more prior arrests. So it really began to tell a story of the cycle of criminalization. And then we took that study and expanded it statewide. Wanted to see if the trend we were seeing on the criminalization was just across the population that was being served at Napa, recognizing that Napa typically serves more of our Northern California counties, and wanted to explore whether or not we were seeing that same trend across the other counties in California and the other across our other hospitals. And so we did a kind of time-limited short-term study looking at admissions across several months. And what we saw is that overall in the diagnostic and demographic profiles, the same data we were seeing, we saw the same significant rate of prior arrests across the individuals that we were serving across all counties. And what we did in this study is there was, a lot of discussion at the time and a significant rise in our homeless population in California. So we took a look and added a review of our admissions to see what their status of sheltering was at the time of arrest. And ultimately, we found that of the population that were admitted, 47% of individuals being committed to us as incompetent to stand trial were unsheltered homeless at the time of their arrest. And then we also matched our data to the Department of Healthcare Services Medi-Cal data to see the utilization of the Medi-Cal benefits across individuals that were committed to us. And we found that 47% of individuals that were committed to us had not accessed any Medi-Cal benefits in the 6 months prior period leading to their arrest. So really, what did this all tell us is that what we saw is that across the individuals that we're serving, we're seeing individuals with schizophrenia, spectrum disorders who are drifting into untreated, unsheltered condition. These conditions are leading to increased contact with police and criminal charges. This increased contact is leading to a surge in IST referrals to our state hospitals, and that building more state hospital beds is only going to exacerbate the problem long term, that we're just creating opportunities for individuals to be committed in as IST rather than addressing the front end challenge that is contributing to this trend. And the IST restoration pathway is not adequate long-term treatment plan. So we do add to our presentations generally vignettes that kind of tell the story of who we're serving, and this cycle of criminalization and the reflection that individuals that are committed are getting felony crimes really are just symptoms of untreated mental illness and escalation as the police are called out and the engagement with officers, and what ultimately results in some felony charges. And so as an example, in this case, we have a 35-year-old male where the police were called because he was on a roof, pulling roof tiles off the residence and throwing roofing tiles down off the roof. And the officers, when they came out, they ultimately ended up throwing the tiles towards the officers, and after all of what occurred at the scene, this individual was charged with a felony aggravated assault on a police officer and felony vandalism. And we include these to show that generally it really is this escalation that happens, it really to demonstrate that individuals really this is not where they should be, that we just need to figure out a pathway to connect individuals to treatment rather than to having them end up in jail, where they are then on this pathway to an IST commitment charge. So we have several of them in here. I'm going to, in the interest of time, just continue on. Does an IST commitment help? And so we looked at, when you think about the purpose of an IST commitment under the penal code is short-term treatment, just to restore them back to competency to go back to trial. We have looked at the 3-year recidivism rate. So this is 3 years post-discharge from an IST commitment, the recidivism rates. And what we found is that individuals who end up on this pathway, we ultimately see fairly high recidivism rates across the 3-year period. And then looking at the 3 years of discharges that we looked at, 15% of them, of the felony ISTs, had a single offense. And post-discharge from DSH, 35% of them had their charges dropped ultimately. And then across the 3 years of IST discharges, 85% of felony ISTs had multiple offenses. And post-discharge from our department, 24% of them had their charges dropped. And what this shows is that while they're getting felony charges, ultimately, most of them, a good substantial portion of them are getting dropped after their restoration. And so ultimately, what is the value of the arrest and state hospitalization to just have their charges dropped and ultimately go back to the community and released from jail, rather than at the front end connecting them to the individual to treatment. Where do ISTs go after the IST discharge? Taking a look and to see ultimately what happened, knowing that again, the 1370, the Penal Code 1317 incompetent to stand trial process is designed to restore to competency to go back to trial. Ultimately, only 25% are found guilty of their crime and are sentenced to prison. And we're committed to a state hospital. So a large portion of individuals are, again, having their charges dropped or have a low enough offense where they are remaining at the community, at the county level. So we also took a look at, we're starting to take a look at our wait list, and knowing that it has grown substantially and trying to understand who's on the wait list and if there's other opportunities for individuals, and taking a look at the crimes and the clinical presentation of individuals. We see that about 47% probably meet diversion eligibility and could be diverted from this IST finding and from the state hospital pathway and waiting in jail from a bed. So what have we been doing to address this issue? Well, we have focused in a number of areas, really looking at capacity expansion. Initially, that was the focus. Then we looked at systems improvements. And then finally, in the most recent years, how do we really focus on the demand side and reducing the demand? So for capacity increases, we already went over this slide that showed the increasing number of beds that we have activated, both the state hospitals, jail-based treatment beds, as well as community-based restoration beds. We have done a number of items for systems improvement. As an example, we established a patient management unit where they accept the centralized IST referrals now, where they used to go out to the state hospitals, and we can manage all of the beds to make sure that as a bed comes vacant, that we're moving folks into that bed as quickly as possible. And that, and we've also worked to reduce average lengths of stay so that individuals are being restored faster now, and we are able to serve more individuals in the very limited beds that we have. There's been a number of legislative changes across the years, really designed to try to make the IST commitment an efficient commitment, meaning that people are not getting delayed anywhere in the process of the commitment, as well as ensuring that those of us who are part of the commitment process have the tools that we need to be able to safely treat individuals. But most recently been focused on demand, and really has been a new policy direction for us. And this is where we really, in the most recent years, have been focused on diversion. As a system, we recognize that the best thing isn't for them to be, for individuals to be treated in our state hospitals or our jail-based competency programs, but really focus on the opportunities for diversion and into community treatment, and really having their felony charges being relieved from their felony charges. So we now operate the DSH diversion program, where we are providing diversion opportunities, funding to the counties to provide diversion opportunities for individuals who are found incompetent to stand trial on felony charges, with the three primary diagnoses of schizophrenia, schizoaffective disorder, and bipolar disorder, where there's a connection between the charged crime and their mental illness, or the charged crime and homelessness, and who can be safely treated in the community. This was made possible by AB 1810 and SB 215. This is the law that established diversion for individuals with serious mental illness. And in 2018, we were provided $100 million in funding to be able to partner with counties to be able to offer these diversion opportunities for individuals who've been found incompetent to stand trial. We are currently partnering with 24 counties throughout the state to provide the post-booking diversion opportunities. And the goals of our diversion program are to reduce IST referrals to the department, demonstrate effective strategies. This is a pilot program currently, and so the goal is to demonstrate the effective strategies and programs for treating people with serious mental illness and criminal charges in the community, connecting individuals to long-term community treatment after diversion to reverse the cycle of criminalization, and reducing stigma. Most recently, in response to this growing wait list as a result of the pandemic, there's been a sizable investment to try to also kind of address the challenge that we have today, where we are have such a significant number of individuals who are in our jails who are waiting services, and how do we get treatment to that number of individuals. And so there's been a sizable investment in capacity expansion for, particularly at the county level, we have a $250 million investment for us to contract for subacute capacity to build out community-based restoration expansion, an expansion of our conditional release program. We are also going to be funding some jail-based competency treatment expansion, but that is not the primary focus. The primary focus is trying to build out capacity in the community to give individuals opportunity to receive their treatment in the community. And then there is some legislative changes around the incompetent to stand trial penal code, most notably that individuals who are found incompetent to stand trial on misdemeanor charges are no longer to be served in a state hospital, that they are to be served at the county level. And then really on the demand side, and a very sizable investment and expansion of our diversion program, as well as the development of a new reevaluation program that gives us the opportunity to reevaluate individuals who have been found incompetent to stand trial, and to see if we can find a pathway for them that does not include waiting a long time for a state hospital bed. So do they qualify for diversion and connecting them to the county for their diversion program? Have they been restored to competency? And so that we can notify the court so they don't wait to get to a state hospital bed to be found incompetent to stand trial, or to be found restored. So a lot of different solutions that are currently in the works, and a sizable investment to really address the problem today, which is the very large wait list. There's also a authorization for the establishment of an IST Solutions Workgroup, which I'll talk about in a few moments. But with that work group, there's also funding set aside to really begin to start quick implementation and rapid implementation of recommendations that are coming from that work group, without having to wait for future budget authorizations as through our state budget process. And then just also want to note that there is a very substantial investment in community care expansion this year in the budget, and there was $2.2 billion in funding at the Department of Healthcare Services to expand behavioral health treatment options in the community, as well as another $850 million at the Department of Social Services for community care expansion, to expand the number of adult residential facilities that we have over throughout California, and just a very sizable investment in building out our community capacity this year. So the Incompetent to Stand Trial Solutions Work Group, and I just want to acknowledge that I see that there's several members today that are joining us in the audience today, who have been participating in the efforts of this work group. This work group is made up of various partners and stakeholders, associations, state departments. I also want to point out that we do have representative from NAMI on this work group as well. And this is a work group that is designed to really focus on a couple of goals, which is generating actionable ideas and solutions to advance alternatives to placement in the Department of State Hospital restoration of competency programs, to submit recommendations to the California Health and Human Services Agency and the Department of Finance. We had a very short period of time to do our work. We formed on August, I think it was in the middle of August, and we had to turn around and produce a report by the end of November of all of the solutions that we have identified. And then we have, again, mentioning that we have $75 million to begin implementing the solutions very quickly. The objectives of the work group are to reduce felony recidivism, felony IST recidivism, increase treatment capacity, increase diversion, reduce lengths of stay, reduce numbers of individuals who are found incompetent to stand trial, and increase access to treatment before transfer to a restoration of competency program. And so there's been 3 work groups that have been formed out of this Incompetent to Stand Trial Solutions Work Group. Has broken down into 3 small working groups who have really focused on early access to treatment and stabilization opportunities. Really, a lot of really good work and discussion around diversion and community-based restoration, and then focusing on the initial competency evaluation so that we don't have individuals being found incompetent to stand trial and put on this pathway when they aren't really incompetent to stand trial. And so really trying to focus on the quality of those evaluations and what more can these evaluators do to help move people into diversion opportunities. So if you're interested in learning more about this solutions work group, I have provided the link to the work group, and it has on this site all of the meetings and the materials that we've shared with the committee around the challenges that we are working towards solving. So finally, just want to really I guess, emphasize that we are really focused here at the department around finding solutions to break the cycle of individuals being found incompetent to stand trial, who are in the community untreated and unsheltered, who find themselves in the arrest, that go to jail, ultimately end up in a state hospital placement, then back to the community, back to the circumstances in which we started this cycle, and then back into an arrest. And so this is we are extremely committed, and the administration has been committed to really focus on breaking this cycle as well. So that has been the charge of late as to how to address the challenges that we have been we've been faced with around the increasing number of individuals that are being referred to the department. So with that, let's see, Harold, I don't know if I'm going to turn it back to you or Angela for questions.
Thank you so much, Stephanie.
Okay. Yeah.
We have a couple of comments, but I don't have any questions. So if folks have any specific questions, you can pop them into the chat. We had a couple of comments that came up on the HUVA side.
Okay.
And I'll share those. The first is, thank you for this presentation. Many charges are not dropped unless there is access to a secure facility. IMDs will not take people who are not conserved. We must not forget those who may not need a DSH bed and certainly don't need a jail bed, but do need a therapeutic setting. We need a system of housing that heals, that will provide diversion opportunities for all. And then another comment here is IST diversion programs are great, but there needs to be more supports in place. The mentally ill are unable to navigate the bus routes, transportation, and all the requirements. The programs are lacking in substance and staff. Step down shelter needs to be provided, and more should be done to ensure a successful outcome. And then last is counties must receive sufficient funding in a quick manner in order to try and accomplish the goals of IST working groups. Otherwise, the only defaults will continue to be either county jail without meaningful treatment or homelessness.
Thank you. Thank you everyone for those comments. And I think we share those concerns that are being shared in that we have experienced that even when we try to move individuals from a state hospital down, step them down into the community, that the opportunities and the community treatment beds are limited, and it's very difficult to transition someone who has had any sort of arrests and criminal history as well. So it's been very challenging, and that's why we're very hopeful that in the future, with the investments that are being made in this budget year into our community systems, that we will start to see a change in that access.
Thank you. And then it looks like we've got time for one question before we need to switch to our second session in this plenary. Let's see, I will. We've got a question from Mark. I'm going to go ahead and, oh, where did he go? I guess.
Can you hear me?
Yes, go ahead, Mark.
Hi, Stephanie, and thank you very much for leading the IST Solutions Workgroup. It's been an honor and an opportunity to be able to comment with the committee. And I have a question that really isn't suitable for the committee, but it's something I hope you'll think about. As I've listened to all the different ideas, and there's lots of really, really good ideas, but many of them are how we take our system, which currently is overwhelmed and broken, and through the, be able to make it function better. So we're trying to take a dysfunctional system, make it function better, but it's still patches and band-aids. And I hope when we get to the long-term goals, we actually have a dialogue either post the work group or as part of the work group, and how we can reimagine our state hospital system. So much of it now, for lack of a better term, and I don't mean this in a derogatory way, but it's become like a factory for FISC clients. 70% of what you're doing is dealing with the statute that mandates people who are felony IST. And as the presentation from Los Angeles showed, we've been able to do it here and drop recidivism rates to 17%. If over a period of years we were able to change that dynamic and actually restore people in the community, we really need to reimagine how we use the expertise of the state hospital system to really rehabilitate people who have committed crimes due to their mental illness, and not just after they're restored to competency, send them off to Pelican Bay or San Quentin. They should remain as state hospitals and get a therapeutic environment and serve their time in a therapeutic environment so they come back rehabilitated and stable people. It's not a question that's really suitable for the specificity of the solutions work group, but I hope we get time to think on a sort of a more macro level that way, because I don't think we're using the hospital system the best way we could.
Thank you, Mark. I appreciate those comments and really have appreciated your thoughtful participation and comments on the solutions work group as well. And I agree. If we get an opportunity and we are successful at solving there's just substantial demands on our system around individuals with found incompetent to stand trial, that will give us the time and the opportunity to refocus and rethink and reimagine how we utilize the state hospital system. We truly see ourselves just as the highest level of care. That we really, the number of individuals that are committed to us and are in our system really is much greater than we think it should be, because individuals really, there are so many of them that are being committed to us, really can be treated at a lower level if the community capacity was there and the supports. So I certainly hope we get that opportunity after the work of this work group, and hoping that we see the success so that we get that opportunity.
Me too, and as you could imagine, I'd volunteer to help.
Thank you,
Yes.
Stephanie, and thank you, Mark, for your comments. And I really think we need to expand that conversation to include the court system, who ultimately makes many of these decisions. Your historical perspective was really helpful in helping us to understand how we got where we are. That continues to still be a problem, and I hope it's one that we'll address, because it's not just the mental health system that needs reform, it's the court system too. And some of these, archaic laws that we have regarding mental illness. So appreciate your perspective, appreciate your presentation. It was most enlightening. And thank you everyone for joining us today. And again, that was very enlightening.